Hello, and welcome to Psychiatry. This training video was made to review the use of handoffs using a standardized tool developed at Montefiore called PSYCH PASS. Before we dive in, let's go through the history for a minute. In 2003, the Accreditation Council for Graduate Medical Education imposed an 80-hour weekly limit for duty hours. It was expected that this change in duty hours would lead to an improvement in patient safety and care as a result of decreased resident fatigue. Although reduced fatigue might have been beneficial to resident performance, there is no evidence to support its improvement on patient morbidity or mortality. However, it became apparent pretty quickly that decreased duty hours resulted in an increased number of handoffs, which, unfortunately, led to an increase in medical errors. Since medical errors are estimated to be the third most common cause of death in the U.S., improving these handoffs is incredibly important. In 2006, in response to this data on medical errors, the Joint Commission on Patient Safety set a new goal to improve communication related to handoffs. In 2011, the ACGME decided to standardize the handoff process, and they mandated that residency programs should ensure and monitor effective handover processes to facilitate both continuity of care and patient safety, and also to ensure that residents are competent in communicating with team members in the handover process. In 2014, the IPASS study demonstrated the use of a mnemonic-based handoff in pediatrics. The mnemonic stands for Illness Severity, Patient Summary, Action List, Situation Awareness, and Synthesis by Receiver. IPASS was implemented in 9 hospitals across the US and Canada, and data was collected from over 10,000 patient admissions. The results showed significant decreases in both medical error rate and preventable adverse effects after the adoption of IPASS. IPASS then became the primary handoff tool in internal medicine and pediatrics programs across the country. Despite this promising evidence on the positive impacts of utilizing a formal mnemonic-based handoff system in pediatrics, a lit review on handoffs in psychiatry revealed that studies on this topic were limited. Here at Montefiore, we met with psychiatry residents, fellows, attendings, and administrators, as well as individuals from Montefiore's pediatrics department, to better understand what the important parts are of a detailed and sufficient handoff. Subsequently, we created Montefiore PSYCH PASS, or PSYCH PASS, and we hypothesized that this adapted mnemonic-based handoff system would be superior to the Excel-based system already in place in the consult liaison and inpatient psychiatry services. The components of PSYCH PASS are as follows. Patient Summary is a one-line summary of the patient's demographics, relevant history, and current assessment. Note that this assessment may be different than that made on the day of presentation. Make sure to keep this updated. Situational Awareness. The patient's acuity and observation status, as well as any additional precautions like fall, seizure, elopement, or privileges like shaving, backyard, off-unit, or if the patient is on a formal behavior plan. Why are they here? What is the acute presenting problem? Comorbidities, for example, poorly controlled diabetes or hypertension. Hemodynamics, relevant vital signs such as orthostatic changes, and labs like metabolic derangements. Pharmacology, PRNs, the current medication regimen including both standing medications and PRNs. Be sure to specify if any PRNs were needed in the past 24 hours. Action list. Anything that needs to be done during the next shift by the on-call resident. Specifics. Anything specific not previously mentioned. For example, recent seclusions, restraints, or visitor restrictions. Also, you may wish to include any suggested interventions that are helpful to use with the patient, such as deep breathing techniques in the event that the patient is anxious or agitated. This is not a list of general day-to-day updates. Synthesis. Verbal repetition from the receiver of pertinent information as determined by the site supervisor. Well, now that we know what the handoff is, where can you find it? The handoff can be accessed by highlighting your patient's name and clicking Write Handoff in the top left corner. There are 2 dot phrases that can be used to insert the skeleton of PSYCH PASS into the handoff. These phrases are .Moses Psych and .Moses Pass. Once the PSYCH PASS skeleton is inserted into the handoff, it can be updated. The handoff should be edited daily at the end of your shift with the most relevant and updated information. If anything significant happens during the evening, overnight, or weekend call shifts, the on-call resident should update the handoff with this information too. Additionally, if there's a new admission during your shift, be sure to add all the PSYCH PASS information to that patient's handoff before the end of the shift. On both the inpatient and consult services, the written handoff is used as a resource for the on-call resident to reference during their shift. Additionally, on the inpatient service, the written handoff is the primary reference for the verbal sign-out that takes place each evening. Verbal sign-out will take place every afternoon at the end of the day shift. The day team and the on-call intern will gather in the resident room to sign out each of the patients on the unit. The key of the verbal sign-out is to give relevant but concise information following the components of the PSYCH PASS mnemonic. Throughout your rotation on the inpatient service, each of you will be evaluated by the chief resident on your verbal and written handoffs, and you will receive feedback on your performance. Let's look at an example of a written handoff for a fairly straightforward patient that you might see on the inpatient unit. The verbal sign-out on this patient may sound something like this. Mr. C is a 46-year-old male with a history of schizophrenia and well-controlled diabetes, who presented with psychotic symptoms in the setting of medication non-adherence. He is psychiatrically and medically stable and is on routine observation. He is on standing olanzapine, which he's tolerating well, and he hasn't required any PRNs this hospitalization. There is nothing to do on the next shift, but something to be aware of is that his brother, Alan, often calls the resident room and we don't have consent to discuss the details of Mr. C's care with his brother. Don't worry, we're nearly done. But first, we want to go over an example of a more complicated patient that you might encounter on the inpatient unit. The verbal sign-out on this patient might sound something like this. Miss R is a 68-year-old Spanish-speaking female with a history of schizoaffective disorder, bipolar type, and a past medical history of obstructive sleep apnea requiring CPAP nightly, who presented in a manic-like state with psychotic features. She is psychiatrically stable and is on routine observation during the day, but requires constant awareness at night when using the CPAP machine. She had one episode of agitation yesterday requiring 1 dose of PRN oral Haldol, but otherwise has been stable and tolerating her medications very well. Medically, she has had episodes of orthostatic hypotension, for which we are addressing by encouraging PO hydration. On your call shift, it's important to follow up on her pending Depakote level. If it comes back at less than 80, then please increase the nightly dose by 500 milligrams to a total of 1,000 milligrams. Also, given her age, please avoid giving any anticholinergic medications or benzodiazepines, should that come up. That's everything you need to know to give the perfect handoff. Welcome to Psychiatry at Montefiore, and good luck.